Good evening, everybody. My name is Marc Conell. I'm an orthopedic surgeon at Sibley Memorial Hospital, and I'd like to speak with you this evening about computer navigation and robotics in total knee arthroplasty. First, I'd like to thank the Gildenhorn Institute at Sibley Memorial Hospital for sponsoring this lecture series. And also, I'd like to point out at the bottom of the Zoom bar, there is a Q&A. Please, if you have any questions that you'd like me to answer as I wrap this up, please enter them into the Q&A, and I'll be happy to answer anything that you might have. I'd just like to also point out, do not use the chat room. That generates confusion, and we'll stick with the Q&A tab there, please. Okay, so without further ado, for those of you who have been to lectures at Sibley, either by myself or by members of the orthopedic department over the last years, you'll know that this format is somewhat different in a number of ways. First of all, I'm talking to you from my dining room as opposed to the lecture hall at the Sibley Hospital Physician's Office building. So that's one major difference. And additionally, my chief technology officer, my daughter, who is away at college. So this PowerPoint that I'm presenting this evening is bare bones, no frills, Marc Conell original without any add-ons from the technology generation. So as I said, I'm an orthopedist at Sibley. I've been in practice for 28 years. My practice straddles interests in both arthroplasty, which is joint replacement surgery, and sports medicine. And those two really merge at the knee. Total knee arthroplasty is an area that I've been interested in for my entire career, really, but particularly with the advances that have occurred in the last several decades, it's become a very interesting and challenging aspect of orthopedics. So first I'd like to review a little history. Going back about 50 years, when total knee arthroplasty was in its infancy, there were huge differences from one type of implant to another, from one brand and manufacturer to another, even from one surgeon to another, as to how those tools and instruments were utilized. Over the next several decades, things started to mature, and a fairly consistent technological approach to total knee arthroplasty included the use of jigging systems or cutting guides that are used. They can be used both inside and outside the bone to get the geometry of the cuts exactly as we want them to be. Having said that, there was, at least in the early decades, and even to a certain degree now within a much smaller error margin, there is room for variance and for error in terms of the angles of the cuts. And that is what the current system has aimed to get, that last 3 to 5% of patients who, where we as surgeons could have done better. An experienced surgeon in the opinion of the American Academy of Orthopedic Surgeons is a total joint surgeon that does at least 50 cases a year. That's a fairly low bar, and I think that the data supports that a high volume surgeon, somebody who does several hundred joint replacements a year like myself and some of my colleagues, the jigging systems that are presently in use should have an accuracy of 95% or greater. Nevertheless, in an effort to try and continue to move things in the right direction, several processes have occurred over the last 2 decades. The first of which really was a combination of both early navigation and patient-specific arthroplasty. The 2 examples that I use are Signature and Conformis. Some of you may have come into contact with these products in the past, or may know something about them from your own literature searches. Signature was an attempt at generating customized blocks that were specific to an individual patient based on MRI findings. So an MRI was obtained, specialized jigs were made, that not only gave us the correct alignment for the cuts, but most importantly, in my opinion, the real addition was to minimize bone loss. In orthopedics and arthroplasty in general, um, uh, the signature allows for very, very substantial improvement in the amount of bone that we take. Conformis actually is a custom implant, and that's been around for some time now. Started to come online within the last decade, but it's been in use for many years now. Um, the signature did get somewhat of a following. It's specific to a brand that is to Biomet, which is a large implant company, but it's one of several large companies. So it never really took off into the marketplace as it might have had it had a platform that was more open sourced, meaning it would be applicable across all of the implant vendors. The Conformis is even more constrained in its applicability in that it's one implant manufactured for one patient. This is a significant problem, which I think has led to the limited usefulness of this device, and is probably the predominant reason why it has not really taken off and has only a very, very small part of the total knee replacement market. That is, you get one implant, it comes in a box with a tool set, and if there's any need for any type of modularity, which happens all the time, if not every day in the operating room, then that implant may or may not be the ideal fit for that patient, or might not have the exact right parts for that patient. And therefore, we generally prefer to have a highly modular system where if we either run into an unanticipated finding intraoperatively, or if there's a problem intraoperatively, we can fix it on the fly because we have such a wide array of types of devices that we can use that are all interconnected, and allow us to basically make changes on the fly. Early navigation came along around that same time, where the computer allowed us to make cuts using our previous devices, our intramedullary and extramedullary jigging systems, and simply advised us, if you will, from afar, from across the room, as to whether or not we were in the right location, if our cuts were within certain parameters for error margin. A very useful advantage. But again, probably the biggest drawback is that these early navigation systems were really very specific to individual implant corporations. So now enter computer-assisted robotic navigation, which is the state of the art and which is coming online now. You're probably hearing a lot about it. There's a lot of direct-to-consumer advertising about it. There's a number of different products available. Each of the major manufacturers has a specific robotic navigation system that's available in the marketplace today. About 5 years ago, Zimmer and Biomet were separate corporations. They merged and are now the largest of the implant vendors. Their navigation system is called ROSA. I will focus on that specifically later because that is the one with which I am most familiar and the one that I actually have access to and am trained on to use. I'll tell you why this is somewhat siloed in just a minute. Other manufacturers and robotic systems that you may hear about if you're interested in this kind of thing are Navio, which is a Smith & Nephew device, Mako, which is the Stryker device. It's been around for some time for partial knee replacements and now more generalized to both hips and knees. And then DePuy has the Attune system. Those are those four manufacturers are probably the largest and most diverse of the implant corporations that are providing both product and service in the United States markets today. So, who is a candidate for a robotic total knee arthroplasty? Well, essentially, it's the same group that would be eligible for a more conventional total knee arthroplasty. The inclusion criteria really are a combination of variables that are discussed in the preoperative period between the surgeon and the patient. It's my job on the front end before we head to the operating room to make sure that you understand why you need a total knee replacement. And then, of course, you have to be the one that says, yes, it's time to get this taken care of. There are general categories of reasons that I think are probably good things to think about if you're considering this in the not too distant future. Really, I break them down into three categories. I think pain is a fairly obvious inclusion criteria. And while everybody perceives pain differently, I think physiologically everybody understands intuitively, because of course we all are humans, exactly what this is. It's simply a matter of tolerance as to whether or not that's the sort of triggering issue that leads you to want to get a knee replacement. So when the pain is problematic enough that it's interfering with activities of daily living, that's the large group of things that one needs to get done on a daily basis in order to get through life, such as stair climbing, getting in and out of a car, reaching your shoes to be able to tie them, things of that nature are all grouped together, and we refer to them as activities of daily living. The second group of inclusion criteria include those things that one wants to be able to do, whether it's play tennis or hike or play golf. That all plays into how much pain one is willing to put up with. If you're willing to, change your lifestyle in order to accommodate to some painful stimulus, such as tennis, let's say, you may choose not to move forward with a knee replacement, at least not yet. And simply, hang up your tennis racket and take to something else. So that's not as important an inclusion criteria as activities of daily living, the things that we have to do. Of course, one has to be a good candidate with regard to medical clearance. There are other issues that can either foster or interfere with one's plan to proceed with arthroplasty. The internist or the primary care physician is intimately involved in the clearance process. Your heart has to be sound. Your dental work has to be up to date, et cetera. So there's a inclusion criteria for medical clearance as well. Failure of non-operative care is an important one, obviously. If you're failed oral anti-inflammatories, guided physical therapy, injectable treatments, including corticosteroids, viscose supplements such as hyaluronic acid, and then there are other products that are available that we do offer that are, considered experimental, if you will, blood products such as PRP and stem cells, which seem to get a lot of press these days, even though they're not really scientifically validated. That is something to discuss with me or your surgeon before, finally coming to the conclusion that your next best option is to proceed with total knee arthroplasty. Presently, and this may change soon, in order to use a robotic computer-assisted arthroplasty technique, it must be done on an outpatient basis. This will probably change in the not too distant future at many of the hospitals and hospital systems around the country. But presently, if we were discussing it today in the office or tomorrow, you would have to be a candidate for outpatient care. Now, in the same breath, Medicare, the Centers for Medicare Services, designates outpatient care as up to and including 2 overnights at the hospital. So that outpatient designation will still be true when this technique is available in the hospitals. Careful post-operative planning for outpatient surgery is obviously critical. You have to have your ducks in a row beforehand. All the medications need to be filled. The physical therapist has to have been in contact. There has to be social support in place, either through family or friends or through other, professional organizations that allow for home health aides and the like. In general, though, I think it's been a substantial evolutionary step to move most of the post-operative care to the home, Patients are much more comfortable. They're much happier at home than they are in the hospital. And I think it pushes people to do more sooner and allows for a more speedy recovery. Honestly, I think that's been a significant observation that we've all noted over the last several years as this has moved more and more towards outpatient. So, what are the advantages of robotic computer-assisted arthroplasty? It is indeed minimally invasive. Now, that is a term that's been bandied about for quite some time, and minimally invasive in comparison with what I think is the real way to approach it. In comparison with what we were doing is as little as 5 to 10 years ago, the procedure is much less invasive. There's no question. But I think that even now, with the advantages of the robotic approach, we're allowed to do even less soft tissue dissection and balancing in order to get the optimal result. One has a tendency to think of arthroplasty as all bone and cartilage and metal and polyethylene, which is the plastic component of the arthroplasty. And that is true, but that's not the complete picture. There's a substantial amount of soft tissue realignment and release that goes on, particularly if there is a significant deformity in a given patient's arthritic knee. You don't see that on X-ray, and it doesn't show up as far as the incision goes. But soft tissue balancing, if you ask any surgery, is what differentiates a good total knee replacement from an excellent one. Making a good looking X-ray is obviously important and is sort of a minimal inclusion criteria for success. Getting good soft tissue balancing to allow things to heal in proper alignment and not have a tendency to recur towards the original deformity is a function of the soft tissue balancing. I think the same day surgery advantage speaks for itself, and I've already addressed that. I've been very pleased to see how patients respond to outpatient total knee replacement in the last year or so. As we've done more and more of it, excuse me, people are very happy to be home. I call patients on the night of surgery to check on them before closing up shop for the day to sort of tuck them in as we normally would on the hospital ward. And it's amazing how generally happy people are to be home. As I said before, the home physical therapy starts actually before surgery and continues either the day of or the day after surgery when the physical therapist who's been assigned to you comes to your home and basically gets you started to walk and move your total knee replacement within hours of surgery. I think the advantages of more intensive home physical therapy, as well as being in the home environment, has allowed reduced recovery time. And I think that part of this is physiological, and part of it I do believe is psychological. People are in so much better frame of mind in their own home environment around their familiar things and their family. They just generally are doing better sooner. And of course, the home physical therapy that is afforded by this technique has been very useful. Improved accuracy is definitely true. You know, we're interested in moving the needle, but as I said before, we do a very good job, 95% plus of the time in terms of the perfect alignment for a knee replacement, but we're interested in moving that to the 99th percentile. And that's our hope, that robotic computer-assisted surgery allows us to move in that direction. Reduced cost is another very important consideration here. Anything that's done on an outpatient basis is going to be generally cheaper than a comparable service rendered on an inpatient basis. This is just a matter of fact. And CMS, again, Medicare and the third-party insurance companies such as Aetna and CareFirst are very interested in cost reduction. And the outpatient technology has definitely done that, and will, I think, continue to push that in the right direction, particularly as our number of implants continues to burgeon. The last time that the American Academy of Orthopedic Surgeons did a manpower study, on this. Within a generation, this is going back about 5 years now, but within a generation, we're expected to do 3 times as many arthroplasties as we have been doing in the recent past. So in order to be able to provide that amount of service to the largest number of people possible throughout the country, like it or not, we do have to keep an eye on the cost equation. Medicare is underscoring that and reinforcing that by encouraging us to do this on an outpatient basis in a variety of ways. What are the drawbacks of this? Well, some patients do require inpatient total knee arthroplasty. There are patients who have substantial medical or other orthopedic comorbidities that require that this be done in a hospital, and that they quite possibly go to an inpatient skilled nursing facility thereafter. So examples of these types of requirements would be somebody with a stable but serious heart condition, or a patient who's got fairly significant Parkinson's, or a patient who's got an amputation on their opposite lower extremity. These are inclusion criteria that Medicare recognizes that would allow us to move the procedure to an inpatient setting and still have to be a covered service. So although the number is decreasing, my guess is that we'll probably wind up eventually somewhere around a 60-40 split, outpatient to inpatient. Those are what the suggested numbers are at this point in time going forward. So it'll never completely leave the inpatient setting. Another drawback is that there's still a bit of siloing in this technology. These are closed source platforms, so that if one is going to use the DePuy computer and robot, it's specifically designed for DePuy implants. Until there's a more open source solution, which I think the market will push towards, and I think that will be the long-term successful model, will be an open source platform where the same computer assisted robot will allow us to use different implants from different manufacturers and different patients for different reasons without having to go to multiple different computer assisted robots. These are very significant capital outlays for the hospital or for the system that is purchasing the computer. So I'm dovetailing into the next bullet point, which is cost. These robots cost anywhere from $500,000 to $1 million. I think that price will come down. But right now, as this is really sort of just past startup phase, the manufacturers are, requiring that there be a payment for the actual computer-driven robot itself. I think there'll be downward price pressure there, but that is a barrier to entry for lots of different situations, whether it's a practice or a hospital system. These things have to be budgeted for. There's an additional drawback, and that is it does add time. It takes an extra 10 or 15 minutes to use the robot, as opposed to a standard intramedullary jigging system. It adds 10 to 15 minutes. Now, we know that whether the procedure is an hour or an hour and a half or an hour and 45 minutes, that all of our intraoperative complications and issues that arise from additional anesthesia time really are pretty flat for the first 2 hours. So the first 10 minutes of a 2-hour procedure is no more or less risky than the final 10 minutes of a 2-hour procedure. If it goes over 2 hours, we start to see increases in complications with regard to anesthesia, infection rates, clotting rates, etc. A standard primary total knee replacement generally takes somewhere between 60 and 75 minutes on an average day for an average patient, perhaps 90 minutes for a more complicated case for myself and for most experienced orthopedic surgeons, that's probably fairly uniform. So that extra 10 or 15 minutes does not really engender any additional risk from a patient perspective, for anesthesia risk, or for any operative complications. So that magic number of 2 hours, we're still well within the limits of that. Although it does add that additional time, so I do consider it a relative drawback. Oops, I'm sorry, I skipped ahead. Okay, sorry, back on track. So I'm going to focus on the Biomet Zimmer system, which is the ROSA, or robotic surgical assistant, because that is the platform with which I am most familiar. It's the one that I'm trained on, and most importantly, it's the one that I have available for use. It is the one that I'll focus on by way of example. I think the others are probably it will turn out to be equally good. I mean, this is analogous to any other, highly specialized technology, whether it's cars. Is there really a difference between a BMW and a Mercedes and an Audi? I don't think that there's a substantial difference. They're both good cars with 4 wheels and an engine. And I think probably the same is true of the present generation of robotic surgical assistants. ROSA happens to be the Zimmer Biomet machine that we have available for use today. I do think that the ROSA has some relative advantages over the others. Its versatility, I think, is unparalleled. As I said, there was a merger between big implant companies a few years ago, between Zimmer and Biomet, and they brought to the table a number of different knee implant systems, including Vanguard, NextGen, and Persona, which from my perspective allows me the versatility and the modularity to deliver any implant to anybody under really any circumstances. So for that reason, I think it does have a leg up on the competition. As I said before, when I touched on the minimally invasive side of it, it's extremely accurate, with minimal bone resection down to the millimeter, which is certainly well within any standard error margin. And then, as I said before, the soft tissue balancing component of the computer-based system allows for ideal correction with the fewest possible soft tissue releases, whether it's the ligaments or the fascia, or the major tendons that we sometimes have to change with regard to length or alignment. It allows us to do that in the least invasive way. And I think that's the part that doesn't really show up on the x-ray or really anywhere outside the operating room, and that only an experienced joint surgeon can really fully appreciate. So that, I think, has been a huge advantage. It's very efficient. As I said, the soft tissue balancing, for example, the intraoperative, there's a little bit of a typo there. That's supposed to be intraoperative 3D modelings, and the next would be benchmarks. But the intraoperative 3D modeling allows us to do that real time in 3D, which is really just remarkable technology just to be able to participate in and to be able to watch. It's very data driven. We get feedback both from the computer and from the robot pre-op, even before we start the surgery. As we're planning for the surgery, there's a whole surgical planning part that goes into it based on x-rays in the days leading up to the surgery. Intraoperatively, we get immediate real-time feedback about our cuts as well as our soft tissue balancing. And then collection of post-op data, I think, will allow us to prove as well as measure post-operative success and outcome in the years to come. This or the further iteration of the robotic surgical assistant that's sure to evolve in the future will change based on the post-operative data that we gain over the next years. We do, including hips and knees, we do well over 1 million of these a year in this country. So there's lots of data-rich opportunity to assess and to review the statistics on this as we go through real time and into the near-term future. So, brings me to my next and final major point, which is outcomes. The goal is to eliminate outliers, whether that's because of deformity or soft tissue contracture. If we can minimize bone loss, optimize implant alignment, and minimize soft tissue dissection to a less and less invasive approach, I think that speaks for itself in regard to the value of this technology in the years to come. It's worth repeating that the standard total knee arthroplasty in the hands of an experienced surgeon is accurate 95 plus% of the time. And we hope to push the limit of that to what we would consider excellent results into the 99th percentile in the future. So with that in mind, I did run over a bit on my time. I apologize. I hope you found the information useful. And at this point, I'm going to move down to the Q&A and take them in the order that I see them. And if anybody has a additional question that they'd like to add here, I'll leave the Q&A segment open while I answer the questions that I do have. I have Ken asking, is there a definite upper age for replacing a knee? Excellent question. I get this one almost on a daily basis, Ken, and I think that it's important to recognize that there's really two types of age. There's chronologic age, that is the year that you were born, the date and time that you were born, but then there's physiologic age. I see patients on a daily basis who are 75 to 85 years of age who are in excellent health, who are really just as healthy as they were when they were 60. They just happen to be 20 to 25 years older, but their medical conditions, their activity level, and all other features of the decision-making process point towards moving in the direction of replacing a knee. So the short answer is no, there is no upper limit. It's really a function of your physiologic age and therefore the risk-benefit ratio that we can calculate together in the office based on the input of all of your other physicians, as well as the degree, the severity of the problem, and measure that against age. I must say that it's not necessarily, I wouldn't say routine, but certainly multiple times per year, I'll replace someone who's a perfectly healthy 90-year-old or even into the 90s. My own personal record was a robust, healthy, physiologically 70-year-old man who was actually 101, a concentration camp survivor who was in perfect health. And I replaced both his knees after discussing it with him, and he lived another 9 years in perfect, well, not in perfect health, but in excellent health with great mobility. So that is my extreme outlier. But I would say that, 80 is not even a thought these days, as long as your general health is good. And older than that, I really think it's a case-by-case basis. But certainly, in your 70s, it's to be considered average to perhaps even lower than average risk stratification overall. So I have Peggy who asks, if you have a custom implant, can the surgeon still do this computer robot model and ROSA? If you have a custom implant, I'm presuming that you're talking about in a different joint, or if you already have one on order, is the most concrete way I can interpret your question. That is, if you were planning on a custom implant and it's already in process at this very moment, the answer is no. That is probably a conformist, and that instrumentation is dictated and constrained by the conformist technology, which is good. It's just, as I stated before, my problem with it is that it's essentially a one-trick pony, and there's no modularity to it. There's no way to get from point A to point B if it doesn't fit perfectly, or if there's a problem in any way, either with the patient or with the implant. It's going to require a second trip to the operating room. I hope that answers your question, Peggy. Ralph asks, do you use ROSA for knee surgeries that don't involve knee replacement? The answer is no. This is specifically for arthroplasty technology. So, for example, for anterior cruciate ligament reconstructions, or for any other knee surgery, reconstructive or reparative surgery, the knee would not involve the ROSA. It's specifically for knee arthroplasty operations. And then Ken asks again, do all the surgeons in your practice use this system? And the answer is that every one of us that does knee arthroplasty is trained up on this system. Short answer is yes. Not all the surgeons in the practice do knee arthroplasties, and so that may be, if there's any dichotomy there, that may be the explanation for that. So certainly ask your surgeon, and if it's one of my partners that routinely uses total knee arthroplasty as part of their practice, then the answer is yes. So that rounds out the list of questions. If there's anybody else that has anything, I'd be happy to answer it. Otherwise, I'm going to turn the floor back over to Kathy Pulford for a wrap-up. Kathy?
All righty. Thank you, everybody, for joining us this evening. We hope you have a good evening. If you have questions, you have Dr. Conell's email address right there and his office phone number. And again, thank you for your interest in joining us this evening. Good night.